Hello everyone, today we'll be talking about how to optimize PEEP. We'll divide the PEEP into two parts as it's a pretty long topic. In the first part we'll see how PEEP works, and in the second part we'll talk about how to optimize these numbers on the ventilator. So PEEP is a constant positive pressure which is applied throughout the respiratory cycle, and this helps you splint your alveoli open and prevent them from collapsing. Mostly the PEEP reduces the intrapulmonary right to left shunt, which is the commonest cause for hypoxemia in diseases such as ARDS, pneumonia, pulmonary edema, and atelectasis. Giving PEEP recruits the alveoli and thus lessens the shunt. However, it also causes overdistension of a normal alveoli. So the net effect of PEEP on the gas exchange depends upon the balance between the overdistension and the recruitment. Typically, overdistension would cause worsening VQ mismatch, while improving the shunt will improve the oxygenation. Will the PEEP affect the CO2 level? The answer is most likely not. Certainly, it overdistends the normal alveoli, which causes some degree of dead space, which can increase the PaCO2. However, increased lung recruitment improves the PaCO2 as well. So these things are mostly matched. Using a PEEP also shifts the tidal volumes to more compliant part of the pressure volume curve. So when you're looking at the normal lung volumes, the intrapleural pressure are lower on the top than compared to the bottom. So there's a relative overstretching in the alveoli at the top when compared to the bottom as well. Most of the lungs lie in the compliant portion of the PV loop. If you're ventilating at a lower volumes, you can see that you are not in the most compliant part, as more and more area is falling into this area where there is a relative opening and collapse of the airways. When you apply PEEP in these patients, you kind of shift it back to where it was, to more compliant part of the PV curve. You can see that your functional residual capacity is increased and your ventilation homogeneity improves as well. We talked a little bit about this. You can use PEEP to counter the auto PEEP and reduce work of breathing and help triggering when the patient is on the ventilator. And as you increase the PEEP, you have to match the auto PEEP, an effect which we call waterfall effect. And once you have matched the PEEP with auto PEEP, the trapped air can reduce and patients have much more comfortable breathing. They have reduced inspiratory muscle effort. The diaphragm is in much more normal position and patient triggering is also improved. PEEP also affects the left ventricle function in multiple ways. So PEEP decreases the venous return. You have a normal person who is breathing. Expiration, the intrapleural pressure is -3, and when he inspires, the intrapleural pressure is -8. Now this causes increased venous return and thus increases the cardiac output. Now, when you change this negative pressure with a positive pressure, your venous return drops significantly as the blood has to flow upstream to a much higher pressure. This effect is more pronounced in hypovolemic patient, and we use pulse pressure variation to figure out volume responsiveness, and this is the same principle. However, when you have elevated right atrial pressures, the venous return is not significantly changed. PEEP improves the LV function. It causes decreased venous return to the left side, so decreases your preload and thus your volume status of the LV improves. The other thing that happens is it also improves the afterload of the left ventricle. So let's say, for example, this LV is able to generate 90 centimeter of water pressure. When your intrapleural pressure are -3, the effective pressure that is transmitted is around 87 centimeter of water. When you are inspiring, you increase the intrapleural pressure to -8 and thus reducing your pressure even further. However, when you give them a positive pressure, you augment the LV pressures and thus it improves your cardiac output. We call PEEP as a poor man's balloon pump. So you can use your PEEP to help augment the LV function in patients who have got systolic failure. PEEP also helps pulmonary edema. It redistributes the excess alveolar water into the compliant perivascular spaces and thus reinflating the previously flooded and collapsed alveoli. Now understand that the total amount of lung edema or lung water remains the same. However, slowly with improved LV function from the PEEP, this edema will subsequently improve. PEEP is a pretty much bad thing for right heart. However, let's say this is a patient who is not intubated, has negative intrapleural pressure of -3. His venous return is okay. However, if you give them a positive pressure, it causes increased RV afterload, and thus RV output is severely diminished. You know that right ventricle is not one of the most muscular organ as compared to the left ventricle. Thus, RV cannot generate very high pressures. And if the RV fails, it starts getting dilated. And since both RV and LV are in the stiff pericardium, LV gets squished and your cardiac output can drop dramatically. Thus, in patients with pulmonary embolism, putting them on the ventilator leads to worsening hemodynamic compromise. The PEEP shifts your cardiac output and venous return curves as well. And if you have a normal LV function, your cardiac output is decreased. However, if your LV function is poor or LV ATP is elevated, you are possibly less sensitive to decline in venous return, and thus helps the LV transmural pressure as well. So LV function is overall better when you give the PEEP. However, PEEP increases the pulmonary vascular resistance and makes your right ventricle failure worse. PEEP, it decreases the intrapulmonary right to left shunt and improve oxygenation. This is the main mode why we use PEEP. We also want to keep the previously collapsed and perfused region open and avoid cyclic airway collapse and reopening. Form of injury we call atelectrauma. PEEP will improve the ventilation homogeneity, shifts the tidal volumes to more compliant part of the PV curve, and can counter auto PEEP and reduce work of breathing in COPD exacerbation. It can improve the LV function in a failing left ventricle and improve pulmonary edema as well. It has been shown to protect lung surfactant and reduce BAL and systemic levels of cytokines. However, PEEP is a double-edged sword and it can cause problems as well. And most important is it reduces venous return and thus decreases cardiac output and thus can cause perfusion problems in other organs. It increases the RV afterload, so in patients with acute RV failure, be very mindful of PEEP. It also distends normally aerated regions, thus increases the dead space component, and it can worsen the gas exchange and tissue perfusion. It can elevate ICP, however, once you are using higher PEEP, watch for elevations in ICP, especially in neuro patients. PEEP can result in ventilator-induced lung injury, and we talk about barotrauma, pneumothorax, and subcutaneous emphysema. It can also cause some degree of volume trauma by increasing FRC. So let's understand what an ideal PEEP should really look like. And in this example, we'll just take one alveoli and understand that in a normal lung or ARDS lung, there are various types of alveoli with different PV loops. We are just talking about one at this point of time. As you increase the pressure, the volume does not change significantly in the first portion of your pressure volume loop. When you reach a point called lower inflection point, you have recruited that alveoli. The first portion of the PV loop represents the tidal recruitment, which is cyclic opening and collapse, and this is the one we just talked about as cause of atelectrauma. The next part of the PV loop is where the volume increases proportionally with pressure, and once you reach an upper inflection point, you are going into an overstretching zone. So the ideal PEEP is the point where you keep your alveoli open and prevent the cyclic opening and collapse of the alveoli. So ideal PEEP is somewhere at the lower inflection point or slightly beyond it. The ideal tidal volume is the volume that you require to change your pressure from the lower inflection point to an upper inflection point. Going higher than the upper inflection point will result in overstretching as well. This point typically is the point of plateau pressures and has been shown to be around 30 centimeter. So you want to target your tidal volumes for a plateau pressure of less than 30. PEEP also depends upon the tidal volume, and as you change the tidal volumes, your PEEP requirements or PEEP estimation changes. So always change your tidal volume before you fix the PEEP. So let's try to figure out how much pressure is required to recruit an alveoli, just to get an idea. So here we have an alveoli. The first thing that you would need is to break the intermolecular water bonds, and that typically takes around 15 to 20 centimeter of water pressure. Secondly, you have to overcome the compressing pressures of the pulmonary unit, and this is the pressure of the alveoli on top of that alveoli. So this depends upon where that alveoli is in the lungs. At max, it can require 10 to 15 centimeter of water pressure, depending on the position of that alveoli. Next, you have to displace the chest wall, and the pressure requirement for this is around 5 to 10 centimeter of water. Lastly, multiple other alveoli in the neighborhood, and there's interdependency between them, and you will typically require around 10 to 15 centimeter to open them further. Thus, the maximum amount of water pressure that is required to recruit an alveoli is around 45 to 60. Most of the recruitment maneuver would use around 40 centimeter of pressure to recruit. However, using such high pressure can result in hemodynamic compromise by decreasing the venous return, and it can also result in barotrauma. You have to also remember this, that number of units which are recruitable by this pressure are very few in number. We have studies on recruitment maneuvers and open lung strategies which have not really shown to be very useful in improving mortality or other ventilator parameters. It can certainly give you a short-term oxygen improvement. When you use PEEP, you increase the functional residual capacity. In a normal person who does not have any recruitable lungs, giving him a PEEP of 10 would result in increased in the end expiratory lung volume. Now, this is just an effect of PEEP and not the result of a recruitment process. So if you have a superimposed PEEP loop, it tells you that there is no recruitment. However, if you keep on going up on PEEP, have a different PEEP loops, this volume is from the PEEP induced volume changes, and this part is the recruitment. So we have an alveolar recruitment and the PEEP induced and expiratory lung volume increase. If you have PEEP loops which lie on top of each other, that means that there is a minimal alveolar recruitment and all the volume increase is from the increase in FRC. Thank you. We'll see you in the next lecture where we'll talk about how to optimize PEEP.